everyone. Welcome to the online workshop seminar today at GlomCon on understanding the genetics of kidney disease. We have 5 distinguished expert faculty speakers today who present on various topics on the genetics of kidney diseases, particularly proteinuria kidney diseases, among others. We have 4 talks altogether scheduled, and the first will be led by Dr. Sayna Norouzi, who is an associate professor of medicine at Loma Linda University, on the burden of genetic causes of kidney disease and diagnostic opportunities. Will be led by Dr. Eric Wallace, who is a professor of medicine, University of Alabama at Brigham, who is one of the leading clinician and scientists on Fabry disease and genetics of kidney disorders. He will be speaking on the approaches to genetic testing and real-world examples. Dr. Margaret Collins will follow and speak on APOL1-mediated kidney disease beneath the surface of CKD in people of African ancestry. And this will be followed by then Dr. Ronan Schneider, nephrologist at Massachusetts General Hospital and medical director of renal genetics at Natera, who will be speaking on interpretations of genetic testing along with Maggie Westmeyer, director of clinical genetics at Natera. Thank you all, and thank you so much, our faculty, for being here to provide education and understanding on the genetic causes of kidney disease to our community. Thank you. Dr. Norouzi, I hand it over to you.
Well, thank you so much for the kind introduction, and thank you for having me here today. I'm actually really excited about this couple of talks that we have today and the symposium that we have. There is a lot of interest about genetics in kidney diseases, and I'm really happy to talk about this today and actually learn from our other speakers as well. With that, I'm going to start with giving an introduction of genetics in kidney disease in general, and then we're going to have talks after me that is going to dive deeper on every topic that I'm going to discuss in the beginning. My objectives of the talk is going to be, so the objectives are going to be to explore the challenges of diagnosing genetic kidney diseases and to highlight the importance of genetic testing in nephrology. And at the end, we're going to review key recommendations from current guidelines on genetic testing for kidney disease. Before I start my talk, I'm just going to ask everyone to answer this question that I'm really curious to know, how often do you actually consider genetic testing in your clinic? And as you are answering the question, I'm just saying that, for example, I have a rare kidney disease clinic, a glomerular disease clinic here. So genetic testing has been playing a major role in my patients, but I really like to see how everyone's answering. And it's really interesting that we have about 36% sometimes, only 12% says always, and 17% often. Thank you so much for answering the question. So that's what we're going to talk about it and see that if we are using genetic testing as we should, or should we order more, and what are the barriers of using genetic testing as a nephrologist when we are practicing and we're managing our patients. So I'm sharing the results with you. And I see that 5% says never and 31% like basically barely. Okay. So with that, I'm going to start with this, that we all see patients with chronic kidney diseases in our clinics. And we all know that the etiology of kidney disease is really complex, and there are multiple factors that are affecting kidney disease. Genetic disorders are one of them. For example, if you're seeing a patient with polycystic kidney disease, Alport syndrome, this genetic testing can be actually changing your practice, how you diagnose these patients. And the way that we get the family history can also lead us to think about genetic testing or ordering a genetic testing for our patients. There are some comorbidities, for example, diabetes, high blood pressure, that we all know. For example, diabetes is the leading cause of CKD in the United States and accounts for about 40% of all the CKD patients that we see. And there are some autoimmune diseases that, for example, IgA nephropathy, lupus nephritis, when your own immune system is attacking your kidneys. And early detection is the key for these patients, because the sooner that you start the treatment, hopefully you can prevent complications for your patients in the future. And sometimes it could be a combination of all of these factors. You might see a patient that has polycystic kidney disease, has diabetes as well, and they might have some autoimmune diseases as well. So it could be really complex as we are sitting in the clinic and seeing these patients. The role of genetic testing and when to order genetic testing, when to consider genetic testing is something that might be more complex than what we think at this point, because a lot of times we think that patient has diabetes, CKD, and we are so used to seeing these patients because it's majority of our patients that they're showing up in the clinic, they have diabetes, high blood pressure, and we might forget about how we can actually think about on a bigger picture and how we can actually utilize genetic testing and how to think about the role of genetic testing and the underlying genetic disorders for our patients. So let's look at even the bigger picture. Are we capturing all the patients with CKD out there? In the United States, about 31% of the patients who are at risk of CKD, they remain undiagnosed despite having some clinical indicators, and that's huge. I always, when I'm giving a talk on these topics, I always say that imagine how busy we are on consults, so when you're sitting in the clinic, and then think about that, like about 31% of people that they might have CKD, they're not being diagnosed as well. So basically our clinics and consult teams can be much, much busier. And hopefully, like, if we can change something in the future, maybe we can catch these patients earlier at the earlier stage of CKD so we can prevent dialysis or transplantation for them in the future. About 9 in 10 adults with CKD are unaware that they have CKD, and that's huge. That's a huge burden on the health system that we have here, and also a huge responsibility for us that how come this is happening, that about 9 in 10 of people out there, they don't know that even they have CKD. And we all know that sometimes, like especially for autoimmune diseases or a lot of other situations, now we have options for diabetic nephropathy. Early intervention is the key, and hopefully we can prevent complications for our patients. So we talked about that probably we're not diagnosing enough patients out there, but what are the challenges of diagnosis of chronic kidney disease? There are some factors that are contributing to not diagnosing these patients. For example, our patients with early stages of CKD, they don't have any symptoms. They feel fine, and a lot of them are being diagnosed in early ages, for example, in their 30s, 40s. They just unaware that they are sick because they don't have any symptoms, and that's not helping with prompting them to come to a nephrologist or to mention anything to their primary care physicians. We recently actually looked into a project about that, how we can actually screen people or healthy individuals, or maybe they don't know that they have a CKD, maybe a urine dipstick or a UA when they come in for the well check visits could be the way to go. And this is something that has been never studied in the US in a large scale. So being asymptomatic is huge. So they are not seeking help because they don't feel sick. And then lack of routine screening. As we said, we don't have any system in place to say that even if you're asymptomatic, I'm going to look at your urine sample, or I'm going to do a urine dipstick today, just because I want to make sure that you're not dealing with any kinds of chronic kidney disease. A lot of times, having like creatinine up and down, when primary care physician sees that in a patient who's completely asymptomatic and they're feeling fine, it goes down to, let's just monitor you for now. And that doesn't prompt timely referrals to nephrologists. And that's something that we need to change for the future. And then the importance of genetic causes. Genetic factors play a crucial role in development and progression of CKD. So if there is a genetic component for the patients, that shouldn't delay the diagnosis. That's the key, that as nephrologists, we always think about the genetic causes, especially when we are dealing with younger patients. When they come to our clinics and something happens and their creatinine is up and they get a timely referral and they show up in the clinic, At that time, hopefully, we're not the ones that we delay the diagnosis because we're not thinking about the genetic causes of kidney disease. Let's say that if there is any role of genetic factors in kidney disease, about 10% of the population worldwide are affected by chronic kidney disease, and millions die each year because they do not have access to affordable treatment. And about over 1,000 genes may serve as possible treatment targets for these individuals. So we all know about the GBAS study that they actually included about 2.2 million individuals in the study, and they were able to identify about 1,026 loci, independent loci, that they are actually related to kidney disease. So that shows actually the importance of thinking about the underlying genetic causes for chronic kidney disease or kidney disease when they come and they show up in our clinic. And the more we are comfortable with using genetic testing in our clinics, that's going to lead to diagnose these patients as soon as possible, and hopefully we can do interventions for them. As we know that the genetic field is actually growing really fast in targeted therapies, the genetic testing, the panel of genes that we are checking for kidney disease, they're expanding really fast. So keeping ourselves updated is going to be the key so we can catch these patients early, and then we can refer them to appropriate trials or appropriate treatment options for them based on the genetic results that we get from these patients. So what is the prevalence of genetic kidney disease? You might ask me that. So I'm sitting in the clinic, what percentage of my patients that probably they're going to have genetic kidney disease, and how aware should they be, and how should I think about this when they are showing up in my clinic about, is there a genetic underlying genetic issue for my patients? About 10% of adult patients with kidney disease, they have some underlying genetic disorders, and up to 50% of pediatric kidney disease cases, they have some genetic underlying genetic etiology. So these are really huge numbers, and I really want us to reflect about our own practice when we are sitting in the clinic and seeing these patients, that do we really think about these numbers? And I believe that whenever I'm talking to our pediatric nephrologists, they are in general more aware of genetic testing, and they usually think more about the genetic etiology, and that makes sense because about 50% of their patients, when they're showing up, you usually think about underlying genetic etiology for pediatric population. But how about adults? Are we really thinking about that when they're showing up in our clinic, or are we just doing routine visits and not thinking about underlying genetic disorders and how we can help them in that terms? There are some number of reasons that why genetic kidney diseases are really hard to diagnose when you are dealing with adult patients. One of them could be because it's just that us as adult nephrologists, we are not in general very knowledgeable about inherited kidney diseases. We feel like most of these IKDs or inherited kidney diseases are happening in earlier ages, and we just don't think that as a huge category of our patients. The existence of atypical phenotypes doesn't help as well, because we always learn about genetic disorders and IKDs in, for example, in medical school and residency, and we have like a typical presentation in our mind. And if the patient doesn't fit the criteria, you might not think about considering genetic testing for these patients. But the thing is that a lot of these patients are showing up with atypical phenotypes, and they have different phenotypes, and that's something that is going to make it even harder and even more interesting to the way that we look at our patients and the way we think about the underlying IKDs. Genetic testing is still not universally available. I can say that it has been getting better for the past couple of years. And in my clinic per se, I don't have any issues with having access to genetic testing, but I understand the limitations of genetic testing not being available in every center. And that's huge as well. And that's something that we need to work on it and change it. And then the conflicting interpretation. Once you order the genetic testing, and this is something that I hear a lot from our community nephrologists, that, once you order genetic testing, you're going to be responsible for the results. You should be able to counsel your patients, and you should be able to actually, when you get the results, you have to be able to interpret that if it's going to be pathogenic for your patients or not. So the lack of knowledge of various genotype, phenotype relationships, if this is pathogenic, the VUS results, these are the things that could be a barrier, and we have to be honest about it. That's as we want to address the issue of how we should actually overcome the problems of diagnosing IKDs in adult patients, is that we should be more comfortable in counseling our patients when we order genetic tests and be able to interpret the results as well. And the other factor is that the family history. You know, when you are dealing with pediatric patients, usually it's easier to get the family history. Patient is showing up with their parents. Parents are really concerned about what's going on, and they provide really good detailed history. And that could be the majority of cases. I'm sure that we have cases that is really hard to get the family history on pediatric population as well. For the adult patients, when they show up in our clinics, usually getting a family history is really challenging. And diagnosing IKDs is kind of dependable on how you get the family history, because these are the clues that comes to our mind that maybe there is a pattern of genetic disorders and IKDs in this family, and I should consider genetic testing. So lack of having that much of detailed information is a barrier, and that's something that is really hard to overcome for adult patients. And sometimes it's just not available. They don't know about it. They've lost their parents all of a sudden. They don't know what happened. For example, you are seeing a PKD patient. They think about they might have PKD, and they tell me that my dad died all of a sudden, and I don't know he's had CKD at that time. We heard that he has CKD. Someone told him that he has cyst on his kidneys. So the family history is really vague, and the patient shows up and they want to know that if they have a genetic disorder that causes cysts because someone told them that they might have this. So it's kind of like sometimes really vague and needs us to be more proactive about thinking how to diagnose IKDs and how to go about genetic testing. The situations that actually helps us to feel like, okay, this, I'm dealing with an IKD situation, I'm dealing with an inherited kidney disease. What are those situations? Of course, if they tell us about the family history, that those are the buzzwords that comes to our mind, that, okay, there is a pattern of injury and I have to think about IKDs. The tubular disease, cystic disorders, as we mentioned, that are huge about genetic testing right now. Syndromic disease, if they have, like, for example, hearing loss, if they have vision issues. Like, you know, these are the syndromic issues that usually, as we've learned throughout our training years, that we know that these are usually pointing us towards IKDs. Congenital kidney anomalies, of course. And then if you are having an adult patient, but they are really young and they are showing up to your clinic and they're 22 years old, 23 years old, and they have some degree of CKD, we always think about, okay, maybe it could be some genetic etiology, autoimmune disorders. And these are like the typical way that we think about our patients. And then FSGS patients, plus minus FSGS, like when you have hematuria, proteinuria, plus minus FSGS, these are the typical patients that in my glomerular disease clinic, I usually think about maybe could be a pattern of IKD for my patients. And then if you have interstitial nephropathy of unknown origin, then this is where you can use a genetic testing to see that if you are dealing with IKDs. So there should be some motivations when you are ordering a specific testing, right? So the same as, for example, kidney biopsies. We usually, as nephrologists, we try to order things that we can use them in order to diagnose, or if it's changing the treatment options for our patients, right? I'm sure that you've had this conversation with your patients in the past about kidney biopsies, that, you know, at this point, I don't think a biopsy is going to change your management. We can just treat you based on the numbers and biomarker numbers that I have, and let's see what happens. Because we always want to think about that, if I'm doing an extra test at this point, is it going to change my management? Is it going to help me to diagnose my patients? And in overall, what am I gaining in order to help my patients? The same as genetic testing. What are the motivations on the nephrologist side that makes us think to do the genetic evaluation for our patients? Again, the first thing is that if it's going to change my therapy plan, if I feel like with genetic testing, I'm going to be able to offer more or something different to my patients, then that's definitely something that I'm going to consider. If I think that there are some extrarenal surveillance for my patients, and if I diagnose IKDs, it's going to affect other organs and it's going to make more referrals to other specialties. And this is not something that is only limited to the kidneys. Of course, I'm going to consider genetic testing. And if there are some ongoing in clinical trials that my patient might qualify for it and might benefit for it, because IKDs, basically, you don't have a lot of treatment options for it, definitely I'm going to consider genetic testing. And sometimes it could be about like you want to tell them more about the prognosis, a more understanding of the disease that you're dealing with. So these are the situations that you feel like my patient is going to gain and they're going to benefit from the results. So I'm going to go ahead and do the genetic evaluation. And what are the benefits and what are the gains and motivations on the patient side? A lot of times when we are thinking about IKDs, patients, they want to know that if there is a risk to their family members. So in my clinic, most of the times, a lot of patients, especially female patients and male patients that are younger, they want to know that if it's going to affect the next generation. If they are thinking about family planning, they want to know about the details of like, if this is a genetic disorder, what type of genetic disorder is that? Can I still have kids? Or my kids are going to be affected? Or if they have kids, if they have young kids, they want to know if they have to look for any specific symptoms. Do they have to start evaluation for their kids as soon as possible? And then if they are doing the family planning, then they want to know that what are their options if there is a really huge penetrance of the genetic disorder for their next generation. They want to know about their options and they want to know about how they can plan ahead. And then the access to disease community is really important as well. Once you get diagnosed with IKDs, there are communities that are you can get support from them, you can get more information. And I always feel like the more you know about the situation that you're dealing with, then you can advocate more for yourself as well. A lot of my patients with IKDs, they show up in the clinic and so like, I've heard about this study, or I've heard about this new gene therapy or something. Do you think that I'm going to qualify for it? And that's something that we want to see in our patients. We want them to come to the clinic and advocate for themselves for more options and newer therapies. And then a lot of these patients have been dealing with, do I have IKD? Do I have a genetic disorder? Or it's just, a primary kidney disorder, for example, they are dealing with some kind of proteinuric disorder, and they don't know if there is a genetic component to it. And with genetic testing, you just tell them the actual diagnosis. So like, is this so far what the information that we have from the gene panels and kidney disease, if you have any specific genes out there. And that's going to give them kind of like the final diagnosis that they've been looking for years. So basically what we have in common with our patients, we really want to clarify the etiology of disease that they're dealing with. And then we want to tell them more about the prognosis, what's going to happen in the future, and maybe more treatment options might be available for them once we know about the underlying genetic etiology. So let's see what techniques we have in order to diagnose IKDs. And this is such an interesting topic. And I know that we're going to dive deeper on these topics on the next talks. So let's just touch base on these techniques and see what we have. Targeted gene panels is something that I think is more common in routine practice. And it's going to examine specific genes related to a disease simultaneously. So the good thing about the targeted gene panels is that you have a high depth of sequencing. It's cost effective. It's not as expensive as other techniques. And it's really easier to manage the data set that you have. It has some limitations. Of course, it's limited to predefined genes. Basically, you are looking for specific genes that has been defined in the past. And then when you are ordering the targeted gene panels, they're just going to go in there and they're going to look for those genes that are already predefined. So basically, you might miss something. You might miss some broader genetic variations on this when you're using targeted gene panels. But in general, that would be usually the first step when you're considering genetic panel for your patients, and targeted gene panels are really easier to access, as I said, more cost effective. And usually when you talk about genetic testing, your patients ask you about the cost and if they have to pay anything. So it could be a good starting point. And in some specific situations, you might use another technique from the beginning. Then we have the next generation sequencing technology. So this is a massively parallel sequencing process of millions of reactions simultaneously. So it has some strengths. It's actually going to detect various genetic variants, but it has a lower sensitivity for basically large structural variants, CMVs. And that's something that has been we've been discussing about that. And it's something that is available in some clinics as well. And I usually, before using the technique, if I'm not using the targeted gene panels, I usually try to kind of make it in a really simple language to kind of explain that to my patients, the limitations of the genetic testing right now as well. Because if you're using the targeted gene panels, and this panel might evolve and is evolving over time, and in 5 years, we might define more genes in at that time, if they repeat their genetic testing, they might have different results and something else might come back positive. And that's something that I want them to know about the limitations and what's going to happen in the future. Like in 10 years, if they repeat their targeted gene panels or next generation sequencing, do they get the different result or not? And then we have whole exome sequencing. So this is the term, this is the technique that you're going to target all protein coding genes in the genome. It has some extra strengths. It's really comprehensive, and it's going to identify genetic causes even when previous test fails. So basically, if you want to know more, you can actually use whole exome sequencing, but it has some limitations as well. The thing is that for the whole exome sequencing, you're only looking at the coding regions. So it's not going to read the non-coding regions. So you might actually lose some part in the comparing to the whole genome sequencing. And that's going to be related to the non-coding regions. The whole genome sequencing, basically, it's going to generate vast amount of data. It has a higher cost and it has a complex data analysis as well. So if you are considering whole genome sequencing as a nephrologist, you usually need to have a genetic counselor for that. And that's something, a limitation on our side, that I honestly, when I'm dealing with whole genome sequencing, I really need a genetic counselor there. I need a genetic specialist to actually walk me through the data analysis. It could be really complicated, but it's basically interpreting the gene for you, and it's most comprehensive, and it's covering the both coding and non-coding regions. So in some situations, you might consider this in some IKDs that you are actually counseling for patients, for example, for family planning, and then you can consider the whole genome sequencing. But as I said, usually your patients, they have to pay for it extra, and for analysis the data, you're going to need support. And then you have the chromosomal abnormalities detection that we are really comfortable with this. It's going to identify chromosomal anomalies through karyotyping for our patients. It has some limitations. It might miss smaller genetic variants, and it requires a specialized techniques. But this is something that basically we are comfortable with it, and we've learned about it throughout our training years. The whole exome sequencing, that's something that I want to touch base, is that it gives you a lot of information as well. And it can be used in a lot of situations. As we said, it's just not going to read the non-coding regions for you. And that's one of the limitations that I discuss with my patients, that, there's going to be some areas that we're going to miss the data, but it's the non-coding regions, and hopefully it's not going to affect how much information we get. And then we want to know about the clinical interpretation of genetic variants as well. So basically, the guidelines are going to classify variants into 5 categories for us. There's going to be pathogenic, likely pathogenic, uncertain, significant, and then benign, likely benign, and benign. So these are the categories that you usually see when you order genetic testing, and being comfortable about how to counsel your patients on this is going to be the key. You usually have, like, if you have a specialized clinic, they usually have access to a genetic specialist that they're going to help you with interpreting the results if you have any questions. But at the same time, the more you know, you're going to be more comfortable about using genetic testing and actually counseling your patients on that. It helps you to have a framework. So when you see these kind of categories, it helps you, like, it's kind of like a starting point of interpreting the results, saying that if this is pathogenic for my patient, or the VUS, and how you interpret that for your patients. And then you have this group of, like, you get a list of VUS when you're ordering genetic testing, and could be a large category of VUS, and then how you interpret that and how it's going to affect your patients in the future, that's going to be a bit more complicated, because you only have 5 categories as being defined by the guidelines, and we probably need more detailed guidelines about how to interpret genetic testing results in the setting of kidney disease. And then, of course, you're going to need to involve other centers. You want to actually talk to genetic specialists, psychologists, and then genetic counselors. This is not something that you can do like you order genetic testing and you take care of everything yourself. You want to provide comprehensive care. For example, in my clinic, I have access to genetic counselors, genetic specialists, and a lot of times I get like a really detailed like genetic testing results sometimes of that which is really kind of like you want to navigate and how you're going to interpret that for your patients. I usually talk to our genetic specialists or genetic counselors even before approaching to my patients to discuss the results with them. So this is something going to be a multidisciplinary approach and requires a lot of coordination among different specialists and actually like before going in there, sitting down and talking to your patients about interpretation of the results. In my experience, I do a lot of genetic testing. I can tell you that about 90% of my patients in my clinic, because of the type of patients that I deal with, they get the genetic testing. And a lot of them, they are super excited about the results. It's genetic testing, the name and everything. So they really want to know everything. They feel like it's going to tell them a lot about the future. So how you interpret that for the patient, it might cause anxiety, and it could be really something that you can prevent that for your patients if you have a detailed conversation with other specialties before approaching your patients. If you are actually revealing some huge news over the genetic testing, you have to involve psychologists as well, because as I said, I always see that excitement and being nervous even before knowing the results in my patients. And that's the last thing that I want to cause with including genetic testing in my practice. So the importance of gene panels of the kidney disease. What are the roles of the gene panels in the setting of kidney disease? The gene panels actually allow us for simultaneous testing of multiple genes associated with kidney disease. They enhance our diagnostic accuracy and actually speed the providing comprehensive genetic profiles for our patients. Gene panels actually can potentially identify rare and common genetic variants, and that's going to help us to have a precise diagnosis. We always talk about this in other situations when we are talking about nephrology topics, that you really need to have a precise diagnosis to be able to treat your patients effectively. And that's the reason that, for example, for glomerular diseases, we consider kidney biopsies because we want to know exactly what's happening. So in order to be able to offer them the best treatment options out there, we really need to know the precise diagnosis, what's happening, what's the exact diagnosis, what are the options out there. And genetic testing can help us a lot with precise diagnosis. And the benefits of genetic testing for our patients is that it's going to improve patient outcome through targeted treatments. So of course, if you know about some specific genes in your patients that is causing the kidney disease, you're going to use more targeted treatment for your patients. It's going to cause, if you are able to have to detect these patients early, then you're going to be able to prevent complications for them. And again, everything is going towards individualized treatment. And with genetic testing, that's one of the main components of individualized or personalized treatment for our patients. So that's going to be one of the first steps that you take if you want to individualize the treatment for your patients. I can say that, for example, I have a PKD clinic here as part of my rare kidney disease clinic, and a lot of patients show up with cystic disease and they have some cysts, and there is this component of unsure family history, and they want to know about if they're dealing with PKD and what options they might have if they get diagnosed. And that's huge. Like just as an example, that if you diagnose these patients early, then you might be able to offer them treatment. There are some ongoing clinical trials right now with the type of the genetic disorder that they have, PKD1, PKD2, or other genes that we have, which the guidelines just got released recently. Then you can actually give them more information about the prognosis of PKD that they have. Not all kinds of PKD are the same, and based on the underlying genetic etiology, they're gonna receive different counseling. And that's the first step that you take when you want to individualize treatments. Or I can actually use an example of like Fabry disease that, once you diagnose these patients early, a lot of them, they have unexplained symptoms, and they have different phenotypes for Fabry disease. And they might say that I've been always tired. I've been always like, I was hearing a patient story that he said that I was, all of my brothers, they were really athletic. They were doing great in high school, and I was always the tired one. I was never able to keep up with them. And he didn't get diagnosed until later. So, like there are some different presentations of IKDs, and that patient, when diagnosed, he already has some degree of CKD. So these kind of different presentations that patients might have in the setting of IKDs, and thinking about like prompting genetic testing and looking for genetic etiology, that helps us to diagnose these patients early, and it can actually simplify or actually help them to prevent complications for the future. And that's our role as nephrologists. If you're sitting in the clinic and missing these patients and missing these opportunities to save these patients from all kinds of like issues that they have in their lives and then complications in the future, probably our job is incomplete and we're not doing a great job. So I have another poll question here. I talked about a lot of barriers of ordering genetic testing for our patients, and I really want to hear from our audience that. So this is the first question, Rika. So this is different. So we answered this question about genetic testing, but at this point we want to know, how, based on your experience and point of view, what are the main challenges that you see in your practice when you're diagnosing genetic kidney disease in adult patients? So basically, what are the barriers of basically ordering genetic testing? And it could be limited availability of genetic testing, as we talked, lack of awareness and knowledge about inherited kidney disease, atypical phenotypes, as we discussed. And it's really hard, actually. I was working on a review paper on Fabry recently, and it's amazing how different presentations you're going to see in patients. And we all know about like Fabry is such a rare disease, and you usually think about a typical presentation, and you want to see those patients that are fitting the criteria in order to think about this diagnosis. And that's not the case. And having atypical phenotypes and presentations, that's something that is going to complicate your diagnosis. And then incomplete or negative family history, again, is something that it's going to affect how you're going to think about the underlying genetic disorder. And then conflicting interpretation of genetic variants, that's another component that probably it's going to affect how you're going to go about genetic testing. So let's see what guidelines are telling us at this point, because I know that as nephrologists, we are really data and guideline driven, and we want to know what is out there and what are the guidelines for the practice at this point. We want to know when to order genetic testing, and this is based on the guidelines. And basically, if you have a patient with a family history of kidney disease or kidney failure, that's an indication for genetic testing. So a lot of times, I can tell you, like a lot of our patients, when they come to the clinic and you ask them about family history of CKD, it's usually positive. And that's an indication to think about genetic testing and considering looking for genetic etiology for underlying disease as an underlying disease for your patients. Early onset, if your patients are actually showing up before age of 50, it's something that we want you to think about underlying genetic etiology. And that's huge. I don't know about you, but I usually when you see patients in their 20s, it's really easy to think about genetic etiology because they are super young. They are sitting in front of you and you feel like you're super young to be sick. What's going on with you? And there could be some genetic etiology. It just naturally comes to our mind. It's like seeing pediatric patients. But when they are in their 40s and 50s, you might feel like, okay, well, you've had diabetes for a long time, you've had high blood pressure for a long time, and that might justify why you have CKD stage 3 at this point. But based on the guidelines, if you're seeing a patient before age 50, that's really young, and you have to consider genetic etiology for them. If they have unexplained kidney disease. So I actually see a lot of these referrals in my clinic because I always say that refer those patients that they don't have diabetes, hypertension, and they have hematuria, proteinuria, and you don't know what's happening to them. And probably that's the patient population that is going to deal with kind of rare kidney disease, glomerular diseases. And I get a lot of referrals of those patients that are unexplained kidney disease. And these are the patients that, based on the guidelines, though, you actually want to consider genetic testing for them because you might think that what's happening? Like, why do you have this kind of degree of CKD and low-grade proteinuria for your whole life? And usually they tell you that, yeah, I've heard that I had protein in the urine 10 years ago as well. And they usually have some degree of CKD. It's not kind of RPGN type. And if you ask really like detailed family history, you might find something in their family history. They might have other symptoms like, typical, like, for example, Alport syndrome in female patients, that they might say that, I'm some family history, they might remember some clues that you think that, okay, I really want to know what's going on. And then you have to think about a genetic panel for them as well. And then some specific genetic markers as well. Some specific genetic markers such as APOL1 variants in individuals of African descent. And that's something that's a lot of ongoing studies are APOL1 variants are going to help us to get more information on this and have a better understanding. But a lot of times I get referrals of my African American patients here that they have unexplained CKD and they have some degree of high blood pressure, which is not that high like this. The blood pressure is in 130s, 140s, and they have some degree of CKD stage 3, CKD stage 2. And those are the patients that you really want to consider genetic testing as well. And again, this is not based on the opinions, it's based on the guidelines that we are saying that we have data on this, and you need to consider genetic testing for these patients. So hopefully we can diagnose them. And then what are like the importance of the genetic testing? That's the next level that comes from the guidelines. Again, as we said, it's going to give you the diagnostic accuracy. So you really want to know what's going on with your patients. If they have unexplained chronic kidney disease, don't let them go and say that, okay, let's just monitor. Your kidney function has been stable for the past 2 years. And as long as everything is the same, we're just going to monitor you. I feel like everyone deserves to know what's going on with their kidneys if they are dealing with CKD. And if we have access to genetic testing, that's something that would be the first step to diagnose these patients and give them an actual diagnosis. Once they have the actual diagnosis, they're going to have access to personalized treatment. It's going to open door like to many options. It might actually, for example, if you diagnose someone with APOL1 variants, then that's going to be a different story. You're going to have a different conversation with those patients, different treatment options, ongoing studies, registries, what they can do for the community, what they can do for themselves. So that's going to be huge. And that's something that we don't want to miss in the setting of having like really busy clinics and seeing like a lot of routine patients. These are the patients that we really don't want to miss the opportunity to diagnose them and personalize their treatment options. And then, as we said, early detection. A lot of IKDs, once you diagnose them early, you might be able to actually effectively prevent complications for them. And that's a really ongoing conversation. A lot of times when we talk with each other as colleagues, say that a lot of our patients, when you go to dialysis units, you see, for example, African American patients or younger patients on dialysis. And maybe if we diagnose these patients earlier, we would have been able to prevent dialysis for them. So hopefully, as we personalize the treatment options, as we have more options to diagnose these patients early, such as genetic testing, earlier kidney biopsies, earlier interventions in general, and more treatment options for rare kidney diseases and IKDs, actually, then we might be able to prevent this. And hopefully at some point, we don't see this younger population at the dialysis units when we are rounding. And then what are the recommendations for nephrologists from the guidelines? Genetic counseling is really essential to help patients to understand the implications of their genetic test results. As I said, I order a lot of genetic testing as part of my practice in the clinic, and I see the excitement and being nervous about the results on my patients. A lot of my patients, even if they are older and they already have kids and they're not in the phase of family planning or getting like trying to get pregnant or anything, they get really nervous because it comes with this pressure of like, what if my genetic testing is positive? And then I have to tell my kids, who are kind of adults right now, but I have to tell them that you have this gene and you got it from me. And that's something that I really, I hear it from a lot of my patients as, you know, I don't know how to disclose, or should I do it? Should I do it now? Is it urgent? Do I have time? So the role of genetic counseling is huge. And I feel like that's not something that you order genetic testing and it comes up on my chart and they can have access to it. They can read it and say like, oh, okay, you're fine. Or they see a list of VUS and say likely pathogenic and they get like really concerned about it. You really need to sit down and spend time. Or if you are not able to do that, then you need to have access to genetic counselors and genetic specialists to sit down and actually go over the results in detail with the patients. I think like at some point as nephrologists would be nice to actually be able to do that. And that's something that I'm educating myself on a daily basis to be able to provide a better counseling every time that I'm ordering genetic testing. And then ongoing education, as we said, this is something that I'm actually working on it myself. And every time that I order genetic testing, I see something new and I feel like, oh, okay, I'm not sure about this. And I reach out to our genetic specialist here. I reach out to genetic counselors that I have access to. I discuss with them. I really spend time. We pull up the genetic testing results and we go over that with each other. I go back and I read about it. And I really try to know as much as possible before my patient shows up after the genetic testing results to the clinic so I can answer the questions. And my patients, they usually have a separate appointment with a genetic counselor as well to go over the results as well to answer like any remaining questions. And then incorporate genetic testing into routine nephrology practice to enhance patient care. That's something that I think as nephrologists, as a community, we have to work on it because the more you use genetic testing in appropriate settings, of course, you're going to be more comfortable. Like, once you see 50 genetic testing results, then you're going to see some repetition at the same as the same as other tests and everything else in medicine that we order. The more you do, you're going to learn it on the job as well. You're going to be more comfortable. You just need only one APOL1 patient that you have to go and see what are the options out there, what are the registries out there, what are the ongoing studies. And after that, your second patient is going to be much easier. Your third patient is going to be much easier. You only need one PKD2 patient or atypical PKD patient that you have to go about and just talk to genetic counselors and everyone. And the next time you're going to be really more comfortable to talk to your patient about the results. So the more we use this and the more we incorporate that into our routine practice, it's just going to become part of our practice as the same as other tests that we order. And over time, we become more comfortable and in ordering that and in order to explain that to our patients as well. So, what are the challenges of suspecting genetic kidney disease for a nephrologist? As we said, we have to educate ourselves, getting this family history, detailed family history, unexpected phenotypes, evolving family history as well. And then the family history, if it's not obtained or if a kidney disease or overlooked in adult patients, then something that it might not prompting us to consider genetic testing. And then we talked about different phenotypes as well. And that's really complicated and really needs a special passion, in my opinion, to look for it. You actually need to think about these kind of atypical presentations every time that you are in the clinic, not to miss any patients. And thinking about that, I think that's going to be the first step, because then you're going to think about genetic testing, further testing, and that's going to be the first step of diagnosing these patients early on. I do get a lot of referrals of atypical presentations that they've been to different doctors actually in different nephrologists, and eventually they show up once they have CKD stage 3 and 4, and at that time they get diagnosed. And hopefully this is something that we can change that in the future. Now we have more access to genetic testing and individualized treatment options. So, what are the explanations? You might ask me that, why do we have the phenotypic variability in IKDs? And it could be because of the allelic heterogeneity or incomplete penetrance, and or maybe if because we have modifier genes as well. So what do they mean? It means that we might have different pathogenic variants in the same gene causing different phenotypes. For example, Fabry disease with cardiac phenotype. As we said, that Fabry disease can have different phenotypes. And the other factor is incomplete penetrance that we can use, again, Fabry disease for this one as well, that, sometimes you have you have X inactivation in female, or like female patients, that basically you might have different phenotypes in female Fabry patients. And that's something that you really need to look for it. Like some female patients might have really mild symptoms, and some patients that actually have really typical presentations, and they might show up to your clinic and you feel like this is a female patient, so probably this is not Fabry, but this is actually an atypical presentation of Fabry with different, like basically a variation of the phenotype of the Fabry. As I said, I was working on a Fabry paper recently, and made me to read a lot of recent papers on Fabry, and it's fascinating how the diagnosis of female patients with Fabry gets delayed because of the different phenotypic features that they have. And the same thing can happen to, for example, AD-TKD patients, or even like I've had patients in my PKD clinic, like they have different phenotypic presentations, and this is not all the patients show with the same symptoms, and that could be because of different, like the heterogeneity that we have in their phenotypic features that they show. For example, the disease phenotype can also influenced by variants in multiple genes as well. One of them could be COL4A3 mutations leading to severe phenotypic features that we have in our patients, and that's something that we see in glomerular disease clinic, and that's something that I usually sit down and I talk to my patients about, that not all the patients are going to show up with the same presentation, and that's the key these days, because we do have disease foundations, and patients, they go and they get connected to the community, and a lot of patients might actually show up with severe features or typical presentations, and they make them think that, okay, my symptoms are completely different. Is my doctor correct? Do I have this diagnosis? And they come back and I ask questions. I actually have the brochures of foundations in my clinic, and I usually connect my patients to the community. So I get these questions a lot, that I'm hearing that my presentation is kind of completely different than my like other patients, and how is it happening? Like what's in my genes that is different, or why am I showing a completely different presentations and symptoms than most of the patients in the community? So again, this detailed counseling on genetic testing is something that is going to be huge. And then you have the mosaicism on the presence of, when you have presence of both mutated and wild type cells in a patient, that can result in a milder clinical presentation. And tuberous sclerosis could be one of those examples that we have. The epigenetic regulation, meaning that you have genome modifications that are not encoded in DNA sequence, which is impacting the phenotype. For example, hyperglycemia, which is triggering chromatin changes. These are kind of like really interesting topics in the setting of when you are dealing with IKDs, and when you're dealing with the genetic testing results, that I usually, when I'm dealing with these situations, I immediately actually do that, like that multidisciplinary approach that we said. I usually involve our genetic specialists here, because these are like more kind of thing that patients, they need to know more about it, because they are showing different phenotypes, and they have the same genes, right? So these are the counseling that are really sensitive, and to explain in a really simple way why your phenotypic features, why your presentations are different. X inactivation, as I said, for example, in Fabry disease or X-linked Alport syndrome, these are the type of disease that you have random inactivation of one X chromosome in females that can actually to change the type of presentations that we usually see in female patients. As I said, for example, in Fabry disease, we usually expect milder symptoms, like really mild symptoms in female Fabry patients. And they come in and they're showing like some features that you feel like, okay, this is really severe for you to have Fabry disease as a female patient. And you might actually question yourself about the diagnosis, but that actually could be because of the X inactivation, those patients. And this is where the more you educate yourself, you're not going to miss this kind of diagnosis, and you're going to be able to provide effective counseling about their diagnosis and prognosis in the future, and about treatment options as well. Of course, if your patients are showing with severe symptoms, even if they're female patients in the setting of X inactivation, then your treatment options are going to be different. Their prognosis is going to be different. Every conversation that you're going to have with your patients is going to be different, because the features of the disease, the way that they're showing the symptoms are different, and they're going to have a different prognosis in the future. And then you're going to have some environmental factors as well. We all know that like there are some phenotypes that are influenced by environmental factors throughout life. For example, lifestyle affecting cardiovascular health in IKD progression. So, like we always have these patients that they come in and you find something on their gene panel, and they might not show a lot of symptoms at that time. And then one interesting question that always comes up is that, uh, do you know of any kinds of anything in my lifestyle that might affect my symptoms in the future? Or is there something that I can do to prevent activation of, like, I don't want to have a lot of symptoms. I know I have the genes, but are there any factors out there that I can prevent? And this is such an interesting topic, which I'm really passionate about it, because once you know about the gene panels, what you're going to do and what you can prevent and how you're going to personalize the treatment options, that's going to be the key. And one of the things that we usually know is that, like, the lifestyle that can affect your cardiovascular health. Like, for example, if you have a specific genes, or they always ask about diet, exercise. So these are really interesting topics that we really need to have more data on it. And the more we do genetic testing and we have more profiles on our patients, and more research that we do about these environmental factors, that's going to help us to have more information. So with that, let's summarize the benefits of, let me see how much time. I'm out of time, so I'm going to wrap up with summarizing the benefits of diagnosing an IKD and CKD patients. As we said, we want to have an accurate diagnosis, because once you establish the diagnosis, then it's gonna impact how you're gonna have these conversations about their future prognosis, what's gonna happen in the future, and then you're gonna individualize their treatment options. You want to know, like, there are some ongoing therapies, gene therapies, and everything. It's like the field is expanding really fast. Sometimes I compare like the genetic field in nephrology to maybe oncology. Like, every time that I'm talking to our oncologists here, they have a new medication out there, or they say like, oh, our approach is changed now, and we're not treating like that cancer that way anymore. It's completely changed from even 6 months ago, and it's fascinating. And I feel like there is this kind of our field in genetics and IKDs is something that is expanding really fast, and actually can compete with oncology at some point, because the more we know about the genetic disease, and the more we have expanded panels for looking for specific genes and targeted gene testing that we do, we're gonna actually look into now what we can do for our patients. Can we do gene therapy? Can we do personalized treatment? Can we actually adjust the environmental factors that can affect IKDs for our patients? And this field can explode and actually can grow really fast. And that genetic testing, and especially when you have precise diagnosis, then you're going to avoid ineffective treatments. You're going to have more options about like enrolling into a clinical trials, and you're going to have more information about donor when you are thinking about transplant. Genetic testing over biopsy, that's something that should be considered. Genetic counseling is expanding really fast in nephrology clinics now. And then a reclassification of conditions. Once you know more about it, then you're going to reclassify that. And that's something that I feel like it might happen to Fabry disease really fast and soon, because as we are doing more genetic testing and we are seeing more data from the registries, you're going to get more information about that. Or maybe Alport disease or FSGS, APOL1. These are like really IKDs that actually they have a lot of potentials right now. And we have kind of a good understanding, and we can move forward and have more options for our patients, reclassify their diagnosis, And also, the last thing is that as much as we want to do genetic testing for our patients, always consider the ethical considerations before ordering the genetic testing. Discuss the options with your patients. What's going to happen once they have the results? What are going to be, like how they're going to feel about that? To share that with their family members or not? What going to tell them about the future? How it's going to change their treatment options? These are the things that I usually discuss out in detail with my patients before ordering genetic testing. As I said, this is something new to our patients, and a lot of times when you say genetic, they feel like, oh, I'm doing something really extra, and they've never heard about it before. But so the more you counsel them beforehand, it's going to be easier to discuss the results afterwards. So, as we said, the guidelines, they want us to think about underlying genetic disorders for patients with CKD under age of 50. And there was a study that actually looked up 125 adults who aged more or equal than 50 years. And about 38% of the patients had some pathogenic variants. And the highest yield, 48%, was in ages of 50 to 54. So when you are saying older patients, then don't think about that there's no I'm sure that there is no underlying genetic etiology, because that's wrong. And as you see, there are studies and ongoing studies actually looking into this, and there is this room that you really need to think about possible genetic etiology for these patients as well. So the positive genetic testing in glomerular disease, as we said, it might help us to avoid immunosuppressive therapy or stopping them earlier. We might be able to allow them to use genetic specific therapies, diagnosis of relatives if they have relatives, kids, and that's going to help them to get diagnosed as soon as possible so we can prevent complications. And sometimes you might actually be able to skip the kidney biopsy for them as well. And that's going to be huge because kidney biopsy is a procedure anyways, although I know that it's kind of not a huge procedure, but at the same time, it's a procedure. And if you can prevent that for your patients with a simple genetic testing, that's going to be really meaningful, and it's going to make a change for your patients. And then, as we said, allowing them to participate in clinical trials. So I'm going to wrap up my talk with some take-home points that adult nephrologists, we really need to expand our knowledge in genetic testing and how we interpret genetic testing results. And investigating genetic causes of kidney disease can help us to diagnose these patients sometimes earlier, having more accurate diagnosis, and hopefully we can individualize treatment options for our patients. And then thinking about that, patients might actually show up with different phenotypes and different symptoms, and that should not be a barrier for us not to think about the underlying IKDs, because as we know, there are different reasons that patients might actually have different phenotypes with the same underlying genetic issues. So that's something that we should keep in mind as we are seeing patients in our clinics. And the potential benefits of diagnosing an IKD in patients with chronic kidney disease is going to help us to actually start family screenings and diagnose those family members as soon as possible. And hopefully we can implement early interventions and prevent complications for those family members. With that, thank you so much for listening to my talk, and I'm here for questions.
Thank you, Dr. Norouzi, for setting the stage and providing great overview about the topic of genetics and kidney disease. Thank you very much. There were several questions throughout the session here in the chat. Thank you very much, Dr. Wallace, for addressing some of those. And I think many of these questions will now be taken care of and kind of directly or indirectly responded to in your talk coming up. So I don't want to take any of that away. Maybe one question for you, Dr. Norouzi, and maybe we can just, in respect of time, keep the response brief. Your general approach to a patient coming in with the new diagnosis of kidney disease. What is your approach to selecting the right genetic testing, whether it's single gene, whether it's a panel, or whether it's an exome testing? How do you approach the genetic testing in a patient newly in your office?
Sure, of course. That's a really good question. I usually start with targeted gene panels, and because it's cost effective, it's easier to order and it's available. If I'm looking for something specific, or for example, my patients are thinking about family planning, at that time I'm considering whole genome like sequencing or whole exome sequencing at that time. But that's my practice, and I start with targeted gene panels at this point.
Thank you very much. And I know that there is more nuance to that that could be reasonably answered in a brief response. So thank you.